Thank you, guys. Thanks for the invitation to speak today. We're going to cover a pretty broad topic, and so this is going to be a whirlwind tour. Coronary syndrome. This is a pretty big talk. I've kind of pared it down to all the really the basic clinical stuff. Starting off, it's important to understand how you manage coronary disease as a whole, because it depends on how the patient presents, what kind of category you put them in, on how you manage the patient. Simple way to separate them up: patients who have asymptomatic versus symptomatic coronary disease. You may say, well, who has asymptomatic coronary? Well, a lot of patients nowadays go in and get screening tests, get calcium scores, and they have no symptoms whatsoever. So a lot of patients are being picked up with coronary disease for which they have zero symptoms. Well, I can tell you, management of asymptomatic CAD is still very controversial. Okay, so we're not even going to go there. Management of symptomatic CAD falls into two broad categories: patients who present stable angina versus patients who with acute coronary syndrome. The key difference there, which dictates therapy, is what's happening at the plaque. In a patient who has stable angina, that's a guy who typically comes to see me. Male or female comes in and says, I've been having more chest discomfort over the last 6 to 9 months. It's been steadily getting worse. There's been a slow, steady progression of symptoms over a fairly long period of time, versus the patient who kind of presents with an acute coronary syndrome may not have any angina or may have stable angina, and boom, you're up. The key difference between those two patients is a patient who has stable angina is simply having gradual narrowing of plaque, of stenosis due to plaque buildup. It's a mechanical obstruction where you're not supplying enough blood to the heart. In acute coronary syndrome, you get plaque rupture. So the plaque destabilizes, and then you get a sudden increase in the plaque formation due to acute thrombus formation. That's the key difference in managing stable versus unstable patients. Acute coronary syndromes can then be defined by two broad categories: what we call non-ST segment elevation ACS or ST segment ACS. For the purposes of the talk, we're going to basically concentrate on these two. Really, STEMIs, the ST elevation MI, is kind of a different breed of patient. And there are subtle differences in the management, which is way beyond the scope. Like, this is going to be the vast majority of patients anyway, unstable angina on it. Now, unstable angina is defined by a clear clinical progression of symptoms. There's a clear uptake in the patients where they previously were either asymptomatic or minimally symptomatic, and then they have a sudden increase. And this can be usually seen as quick transition time. Sometimes they come in with new onset angina. I just had a patient, 50-year-old guy, had a positive CPA, oh, by the way, I've been having chest pain over the last 5 weeks, and it's been clearly getting worse. Sorry, you're not going to get your shoulder. We had a subtotal RCA, 99 pocket right. You can get angina, rest. You have patients who have exercise-related angina that transitions that same symptom happening at rest. That's clearly, so patients who have rest symptoms are very unstable and clear crescendo angina. They may or may not have ST. Not after they're actually at the time of having chest may see okay. And they usually have no or trivial elevation of enzymes, no clear evidence of market. The key point here on unstable angina, everything is based on. Every time one of my residents fellows admits one of my patients for chest pain, the first question I ask them after they see the patient, what do you think? This is a diagnosis. This patient is basically completely treated and managed based on the history that you get from. Non-ST segmental elevation MI is basically an unstable angina patient who has a marker that is having one. That's defined by troponin. So you see a patient who comes in with symptoms, just like the unstable patient, unstable angina patient, we hear different. Now their cardiac enzyme marker that's on top. So either your CKMB or troponin I, whatever you use in the hospital. The thing you have to remember is there's a lot of things that cause troponins to go up. Deficiency, even myocarditis, chest wall trauma, patients who've been defibrillated multiple times can have mild troponin elevation, patients who are post-cardiac surgery. So the simple evidence of the troponin elevation doesn't define a non-ST line. The key thing is you have to have a clinical presentation that sounds like angina plus the troponin elevation. See, the classic presentation if you have a patient 80 years old and has moderate severe cardiovascular disease, that has mild last one, that's been the reason you decided to manage non-revascular. If that guy comes in with urosepsis, it's hypertension for hours, what happens? Why? Because coronary can't tolerate that person may go up. That patient had an not it's a type. We now classify it as type 2I. It's an ischemia event. The difference is that why it's important to separate out. It drives your medical management. That's not. Therefore, a lot of the medicine we're going to be talking about don't apply to that patient. So therapy really comes down to all these things. We're going to go over these individually very quickly. So it's aspirin, anti-anginal therapies, anticoagulants, non-aspirin therapies, antiplatelet therapies. So starting with aspirin, it's still, even in today, it's still the basic antiplatelet therapy of choice. If you look at the ACC-AHA guideline, still class 1 level of efficacy, the highest level you can get with our guidelines. Initial therapy is 3.5 milligrams non-enteric-coated, followed by 81 milligrams of non-enteric aspirin. And that's pretty much stable dose. Really, in nowadays cardiology, only patient treated with 325 milligrams of aspirin on a chronic basis is the patient who has paroxysmal AFib and whose CHAD's best. Outside of that, cardiac aspirin is treated with low-dose aspirin. You pretty much, once they come in with this, they're on it for life issue. What about nitrates? Nitrates are an endothelium-independent vasodilator, and they work preferentially on the venous system, more so on the arterial system. That's the reason why, if your patient non-hypertensive, you give them nitros, their blood pressures many times bottom out, okay? Because their arterial vasodilation, they don't have that much SVR for vasoconstriction. A patient who is hypertensive, you put them on nitrate, he doesn't really do that much blood pressure because it's not a very strong dilator. However, it is very good anti-anginal. In fact, it's effective both for angina and for heart. You can give that either sublingually. Generally speaking, if patients come in with a true ACS event and their pressures can tolerate it, I'll give them, if they're nitro naive, I'll give them topical. The reason is about 10 to 20% of patients will get severe headaches with nitrates. Can't really predict, except if they have migraines, if they have a history of migraines, you really shouldn't. And if you give them an oral nitrate for maintenance, it will last several hours. You give them topical, they get problems. Wear off. Do not use nitrates if their blood pressure less than 90. Some people can get reflex bradycardia, generally don't, especially because of infarct or tachycardia, because they can get reflex tachycardia, and especially if you're on Viagra, Litra, Cialis, last 20 hours, you have to be very careful. When they get refractory, it is by far the most underutilized drug in the management of ACE. Why? One of the things I constantly have to tell my residents and fellows, what the patient presents with is different than what they come in with angina. This is a great anti-angina with very, very few downsides, but it's not something you manage the patient with on an outpatient basis after home. Beta blockers, you guys know, reduces myocardial oxygen demand by reducing your heart rate, blood pressure, and contractility. There's really not a whole lot of solid data for ACS. It's, in total, it's pretty strong. The number one thing just to remember when you're managing a patient is don't be progressive. The one thing that gets us into trouble managing these patients with ACS when they're coming in, they're unstable, is if they get hypertensive. You got to be really careful not dropping the pressure too much by being overly aggressive. These are relative contraindications like bradycardia, hypertension, evidence of low output rate. If they're coming in with heart failure, you're going to be very beta blocker. If they have any evidence AV block, second or third degree, asthma and other reactive airway diseases. In general, patients who have COPD don't have as much reactive airway component asthma. So in general, COPD patients tolerate beta blockers much better than your younger asthma. The ideal patient to use it on the front end and use it aggressively, they come in hypertensive and they come in active. That's the ideal patient. Calcium channel blockers, just all you have to remember about calcium channel blockers is that the second line students don't tolerate. Primarily because if they have reactive, that's the most common reason. They're really second line agents, but it's not something that you cannot use. The one place you got to be careful though for calcium channel blockers is if you know that their EF is low. The problem is that every calcium channel that has been looked at patients with low EFs have done poorly on a long term. Sometimes you have to use it because you don't have the patient to use. But you just want to remember that that's the patient, that's the drug you really don't use in that. It's appropriate to use the dihydropyridine. You may remember calcium channel blockers really come in three classes: dihydropyridines, nifedipine, which is verapamil, and thiazide. Both of the verapamil and thiazide will lower your heart rate so you don't get tachycardia problems. But dihydropyridine, especially nifedipine, can cause reflex tachycardia. Again, that's one thing you don't want to have in patients. The anticoagulant therapy, you kind of subdivided four different ones. We're going to go through this really briefly. It's the old tried and true is unfractionated heparin. Low molecular weight heparins, the most common we use Lovenox or enoxaparin. Ultra low molecular heparins are Fragment and Dreclon. The FDA approved 5 of them. Now, just to make it simple, pretty much the data is decent for all of them. There's really nothing that one agent is clearly better than the other. There's more data for heparin and low molecular weight heparin. So it's given a class 1 level of evidence A indication. But for fondaparinux, it's class level of evidence B, and bivalirudin B. In general, if you want to get practical, these two agents are really not used because these agents are fairly cheap and they're easy to use. So if you're going to use it, these are the only drugs you really want to use. There's really no recommendation to give one over other. There's practical issues to use one orbital. One is that because all the data from ACS clearly shows that early intervention happens always right at relative, generally 20 hours as long as they are with. Even the patients who have unstable angina, who don't have enzyme levels going up, they're clearly having ongoing pain. Those patients we will take that. Okay, but the reason that's important from a practical standpoint is that every single trial looks at low molecular increase in bleeding. So heparin much standard IV heparin much preferable Lovenox, you're going to the lab for two reasons. One, Lovenox cannot measure the level of concentration of Lovenox. Two, it has a very long half-life. So once you stick a sheet in the longer that drug stays around afterward, the higher the risk. In every single trial, the PCI, Lovenox against heparin showed a clear increase in vascular. So for that reason, the vast majority of patients that come in, we put them on IV heparin on their way to catheter. And the nice thing about heparin is you can keep them on heparin literally until they walk into the catheter. You don't have to hold it prior to the procedure. With Lovenox, we typically will hold the AM dose prior to the procedure. The problem is that their last dose is in the afternoon the day before, and the procedure isn't the afternoon the day after, and then you're going several hours, no coverage, anticoagulation. So that's the reason why we usually prefer IV heparin. In general, if the patient, say for instance, comes on a Friday night and it's going to have to sit around, those are the patients that I'll put on low molecular weight heparin over the weekend and switch them over after the procedure. Otherwise, everybody else gets unfractionated standard dose IV heparin. We know that really no use for fondaparinux. Data was not that good. And data for bivalirudin, even though it was okay, it wasn't compelling enough for the significant increase. Bivalirudin is basically $500 per dosing vial per hour. So it's significantly more expensive. So, I've had the luxury because I've been here for a long time, and and I've seen kind of the evolution of therapy. When I started in 1992, our armamentarium for treating ACS patients, whether it's non-STEMI, unstable angina, or STEMIs, basically aspirin, heparin, nitrates, beta blockers, calcium channel blockers, and let me tell you, those procedures they were not good. In the 1990s, really, there are several things that really changed the landscape of management of ACS. When coronary stents were introduced, it drastically changed how we manage coronary disease. A lot of the thoracic surgery guys have been around for a while know that when we did balloon angioplasty, we had a cardiothoracic surgeon in the catheter every day because the incidence of needing emergency bypass was so high. We had to have a team in the room available to send the patient down to the operating room. That basically went away when the coronary stents started getting in the amount of subacute or acute thrombosis of the coronary drastically decreased. The next big one was reduction of glycoprotein. Talk about it later. Then the thienopyridines, or what we call the T2Y12 class of agents. And the second generation of intravenous stents really did it right. Was a huge step forward, quantum leap forward in stent time. All of these things led to less heparin. One of the problems we had, because we didn't have antiplatelet therapies other than aspirin, we used to run heparin, big sheet. you wouldn't believe the number of patients who have vascular complications with PCI. Being able to terminate that made a huge difference with respect to vascular access. We went to smaller diameter catheters, and stenting gave much more definitive results. Significant decrease in post-procedure vascular access, significant decrease in acute and subacute closure, and shorter duration of hospital. But as with everything else, there is no such thing as free lunch in medicine. So as stents became more frequently used, we had problems with restenosis and repeat revascularization, which actually with our current third generation drug-eluting stents has dropped dramatically to well less than 5%. Long-term issues with dual antiplatelet therapy and concern with overutilization costs, which is the whole reason why appropriate snug guidelines. And one of the things that was really interesting in the management of ACS came with this trial that was called the ISIS-2 trial in 1988. It was published in Lancet. It was actually one of the very first thrombolytic that really taught us a fair amount about acute coronary. It was a trial before thrombolytic universal STEMI patients. And the patients who came in with STEMIs were basically randomized into 4 different arms. They either got aspirin, they got placebo, they got 1.5 million units of streptococcus full dose or aspirin and streptococcus, and were watched for just 5 weeks to look at their vascular mortality. The interesting thing is, on this trial, remember, we didn't know what was the best way to treat STEMI. The combined aspirin and streptokinase arm had by far the fewest deaths, more significant. And nowadays we can understand why. But the interesting part of the trial was the patient who was treated with just aspirin for a month did just as well as the patient who got full dose streptokinase. And so you would think, aspirin for 1 month as well as. And somebody got the light bulb going, realized that the primary event triggering coronary is not thrombus mediated by your coagulation test, by your platelets. The primary thing is that was what led to the development of the BDPA receptor. This is the final common pathway by which platelet aggregation occurs. And this was really the first really strong antiplatelet drug we had outside of aspirin, and really changed the management. Because the biggest advantage it allowed is that we didn't have to use heparin post-procedure. And that drastically reduced the number of bleeding complications after. And there's a ton of trial on 2D. And you know, in general, the use of PCA, and part of the reason is because our PCI and stent technology have gotten so good and so much better that we don't need these super potent antibodies. But just if you want a kind of a general recommendation for it, the hotter the patient comes in, okay, out of non-stent that and who has clear troponin elevation, dynamic S changes, and is still having angina thrown at him, that's the patient who's going to get the most bang for the buck, which is starting IV integrity. This is by far the 3 agents that were originally used. This is the one we use most. And I use this a lot on my STEMI patients because it works. You get poisons. And I also will use it selectively on my non-STEMI patients, just depending on how unstable they are. They generally have, the outcomes are clearly better. They have a clear increase, especially and those are things that, you know, again, when we're managing patients, it's important to take into consideration. Use IV integralin. It roughly costs about $570 per vial used. That would last you for several hours. Inhibition of adenosine diphosphate, ADP-mediated aggregation. This is really the oral antiplatelet drug that also changed the landscape for management. The original drug is called, it was in the tynopyridine class, called icopidine or cyclid. And that drug is really what changed intracoronary stenting. We don't have time to go over it, but before cyclid was available, every stent that we implanted back in 1992, and I remember this because it was my first year in fellowship, they were just a royal pain in the rear end. We would put them on aspirin, dextran, xanthine, heparin, and Coumadin. And so every coronary stent patient, and you could not leave the hospital until your warfarin was therapeutic. So you can imagine coronary stent patients run around for about 7 days, every single one of them. And the STARS trial was a trial looking at was aspirin and Coumadin versus aspirin. Of course, the Europeans did this. They're the only ones who have the courage to do really crazy trials that nobody thought was going to be positive, and it was dramatically positive. In fact, it dropped stent thrombosis rate by a factor from 3% on Coumadin to 0.5% on aspirin. And it totally changed. Stenting took off once that trial. And the newest agent, which is a cyclopentyltriazolopyrimidine class, is ticagrelor. They're all fall under what's called the P2Y12. That's the receptor that they work on, receptor inhibitor. Plavix was the next drug, and it was really, it's by far the most studied drug among the class. Capri, Cure, Clarity, and Fit for all trials, looking at multiple different scenarios for ACS. Every single trial came back positive for Plavix. Of the three newest agents, it's the least potent of the three new ones that are used, has the slowest onset of maximum platelet inhibition, but it's just good enough to work really well. And you just have to remember, with all of these drugs, you have to stop at 5 days. Now, one of the common misconceptions people have whenever they hear that patients are on Plavix, that they think that Plavix is potent. It's actually not. If you look at the original trial that put Plavix on the map, free trial, it was a head-to-head trial looking at aspirin versus Plavix. And what that trial showed was that those drugs are basically equivalent. They're not, one's not more potent than the other. The Plavix arm was tiny, a very small improvement, barely hits significance over 2 years. But in general, basically what it says is that they're essentially equivalent. The good thing is that if the patient is aspirin intolerant, Plavix is actually an excellent maintenance drug to use for monotherapy for anti action. And it also reinforces